contact over the mid portion here of the psoas after finding that ASIS. Have them take a breath in, and then you breathe all the way out. And as they're breathing out, you're pushing down pretty firmly in this region. And then at that moment in time, that's when you slowly extend their leg back to a flat sort of position. And what you're doing is lengthening that muscle underneath your contact. So kind of a little bit of a trigger point work or myofascial release here. So that's something to take a look at. I don't know that we have any evidence to otherwise suggest that hypertonic psoas muscles cause hyperlordosis of the spine, but that's another theory. You can see how the insertions here or origins, depending on which way you want to look at it, are grabbing onto all those TPs and moving in a slight anterior position. So that could, in theory, induce a little bit of hyperlordosis. But I'll just tell you anecdotally from my radiology practice, most people either have, slightly diminished or a really reduced lumbar lordosis. So I'm not sure we're all walking around with tight psoas muscles giving us, really good hyperlordotic good or hyperlordotic curves. So, all right. So here's a quick case study for you guys just to kind of mix it up. I'll give you a second to look at these transverse processes. This history is an individual who's had chronic low back pain. I believe they reported a fall in their distant history, so something like a fall off of a horse, where you're falling from a height, you land smack on your back. And what I just wanted to show you here is the transverse processes starting at the level, let's see, well, we'll get to that in a second here, so forget the levels. Right here you can see normal TP on the viewing left, patient's right side, and then this transverse process is a little bit blunted. Unfortunately, the bowel gas gets in the way, but hopefully you can see this okay, where there's a separate ossicle right here, and then another one here, and then a third fracture down here. So this would be kind of interesting in class. I'd kind of ask you guys to think about what do you want to label these segments here. This certainly looks like a good old L5 right there, 4, 3, 2, L1. I would probably end up labeling this as a transitional T12. You can see instead of ribs, you either have really small ribs or costal processes here, or lumbar type ribs. Of course, it'd be helpful to have a thoracic radiograph on this individual to know, is this truly T12 here, or does that fit for T12? And if so, then I'd say we have 5 typical lumbars. But if that's T12, then you have a decision to make. You want to call that T13 or L1 through 6. You can see how it gets messy. That just goes back to those transitional segments once again. Here's an example of somebody with the same type of injury. And this is the importance of rehabilitation and patient education and making sure that they're compliant with you, because so in this case, just to go back here for a moment, you can see we've got healed fractures, healed in the sense that our margins are corticated. They didn't unite, of course. And then they're essentially done. Those are going to be left alone, and you got to wonder what kind of soft tissue injury might progress. In this situation, with a transverse process fracture, it resulted in bleeding that can actually track along the fibers of the psoas muscle or the muscle sheath itself. And in this case, that blood did not resorb properly and actually formed mature ossified bone here. So this is called lumbar ossified bridge syndrome. Don't worry about that. Don't write that down. It won't be on the test. But it's pretty rare. I've seen maybe 2 cases in the wild, so to speak. And it's always interesting. This particular patient was actually in our clinic, referred from an outside doc, and for imaging, that is. And so it's kind of nice. We actually did do lateral bending radiographs just to see, because as you can see here, there's this weird little lucency. We'll call that a pseudo joint. I didn't expect that it would separate at all. But the doc wanted to try these lateral bending just to kind of see if this would shift at all. And unfortunately, I don't have those in the slideshow, but they stayed exactly the same. So this patient's here's another one. They kind of come in droves here. So here's a transitional lumbosacral segment right here, down here. So I'll just call this 5, 4, 3. But yeah, segmental motion is going to be limited here at L3, 4. Okay, so just a little bit of clinical significance with the psoas regarding the lumbar spine. And then here we're going to see this down in the lesser trochanter. Really hard to see. These little avulsion fractures, especially in younger individuals, tend to be very faint and challenging to visualize. So what you're seeing here is an avulsion of the lesser trochanter, that psoas muscle, of course, coming on down and wrapping behind the femur here to insert on that lesser trochanter. And what you're seeing is the mature normal cortex, just like you would here. And as it breaks away, we don't have any corticated bone here, which is why it looks really incredibly faint. So you're going to get the same effect, especially with the lesser trochanter, and then also with the ischial tuberosity avulsion fractures, although the same thing can occur with the anterior iliac spine fracture. One edge and then not the other one. So again, these are just kind of a couple of cases, not really to spend a lot of time studying, but just to kind of highlight the importance of the psoas muscle here. All right, one of the last little ones here we're going to talk about is the psoas minor, and this one doesn't really get a whole attention, and we can essentially treat it more or less as part of the psoas major. However, it's different and unique. In this case, T12 is its origin. Okay, so that's one thing to maybe pay attention to when you have a single origin or a single insertion. Then you should know that. Again, here there might be some variability. I'm just, as we track this up here, this is going to be 5, 4, 3, 2, L1, 12. So I think we can see these fibers blending in to the psoas. But can we be sure that there isn't a couple fibers here going to L1? No, not really. And then you can see it inserting on that iliopectineal line, kind of midway through. All right. So in theory, this will help with flexion of the lumbar spine, right? Psoas major does flexion of the lumbar spine and flexion and external rotation of the hip, because this only crosses that one joint. Think about this as a single joint right here between the lumbopelvic region. It's not crossing the hip, so the only action that the psoas minor in theory would do is flexion of that lumbar spine. So think about it as kind of an assist along with the psoas major. Then the iliacus, of course, I hardly ever refer to this as a single muscle because I think as you'll probably find, most people refer to this as the iliopsoas. So of course it blends together. We've been talking about the psoas major and then the minor here. That iliacus muscle, nicely named for its location, just basically occupies the entirety of that iliac fossa, and then will blend into the fibers of the psoas major here and wrap around. And so what you can expect from an action point here is going to, oh shoot, all right, here's a typo, guys. Sorry about that. Let me see if I can draw. All right, so if you don't mind fixing that, sorry about that. Ooh, there we go. External rotation. Those of you that joined last week saw how bad my mouse was. Well, my mouse died, and now I'm drawing with my trackpad. It's killing me. I want my pen back. All right. Sorry about that. So just a real quick fix there. Hip flexion with external rotation. Same thing as the psoas major. Okay. So just to wrap up this section here, some of the clinical considerations, obviously, as far as terminology is concerned, you should know that you strain a muscle and you sprain a ligament. Those are easy for people to mix up, but you shouldn't, so practice making sure you kind of say those correctly. And you'll hear people say strain, sprain. So if my patient, for example, is in a car accident with a whiplash injury to their neck, they likely did strain some of their neck muscles and sprain some of their ligaments, like those little articular capsules. And so you'll hear people say, oh, I think this patient has a strain sprain, and they lump them together. When you can be specific, though, you should be. All right. The other big thing here, just to highlight, and again, I know you guys were working off of a lecture recording from a previous time here, but I just want to emphasize this issue again here, this fatty degeneration. This is a big deal right here. Fatty degeneration, especially in the multifidus. There's a little bit of research going on with this. There has been for some time. This goes into the theory of why people have back pain or chronic back pain. Why when you have one incidence of back pain does that trigger or maybe make you more prone to back pain in the future? Well, the idea here is that even a short duration of back pain, 1 to 2 weeks, may trigger this cascade of disuse atrophy. Obviously, we don't like to move when we're in pain, and so if a patient does nothing, they kind of wait around, maybe they just take ibuprofen or other NSAIDs or other pain relievers and do nothing else to help rehab their back, those muscle fibers will start to essentially degenerate, and what takes its place is fat. You'll have this fatty infiltration And the multifidus is one that's been studied pretty extensively, and so this is one theory as to why it is so critical to have early intervention in patients with low back pain. There's pretty good evidence to support this notion that if you have an instance of low back pain, you should seek care and spinal manipulation. And then this research, ironically, has been done by more PTs than chiropractors, but spinal manipulation, and I would say I'd send my patient to a chiropractor, of course, just because we have far more training in that, will help prevent long-term effects. And so those individuals who were treated early and also were provided with at-home exercises, as compared to those individuals who did not, the individuals that had no intervention early on had increased recurrence and poorer outcomes and higher incidence of fatty infiltration of the multifidus. So that's pretty cool. So I'd pay attention to this bullet point right here more than anything else on this slide. Compartment syndrome, there's other things we're not going to talk too much about, but compartment syndrome, just to let you know, is an issue where you have an acute injury to a muscle compartment, and immediate swelling can cause loss of or compression of the nerves and vasculature, and it's a medical emergency. So you'll talk more about this at a later time. This is a little bit beyond the scope of the class here. Decongestive back syndrome kind of piggybacks off of this idea of fatty degeneration. So you get injured, you stop. Whoops, that was an accident. You stop moving. You lose some of your muscle tone. Fat comes in. You're not as strong. Therefore, you're more prone to re-injury at a later date, and that then triggers the whole cycle again. So kind of this idea of once you start losing this conditioning. So again, from a chiropractic standpoint, you guys, patient education and giving them home exercises is really important in order to prevent recurrence like this. It doesn't take a whole lot. You don't need to send them to the gym and do a ton of deadlifts or anything else like that. These are simple things like cat and cow stretch, planks, anything like that. That's fairly simple, and you can modify it for any patient population. So that's important. I think that's pretty much, that wraps it up for this slide right here. Obviously, I think we've all experienced some muscle spasms before, and if you have an abrupt pull on it from a muscle contraction, you can cause a avulsion fracture at various apophyses throughout the body there. All right, that's it for that slideshow. I'm going to try to transfer over here. Okay. So I think we're still recording, I hope. Let me just double check that. Okay, and I worry I might have been recording the wrong one. I'm going to hit pause on the recording here. Okay. Do you guys have, oh, thanks, John. Audio is very good. That's good to hear. All right. Do you guys have any questions about section or anything else that kind of, otherwise we'll probably just move on with some additional information for the intervertebral discs. So I'll give you a second. I'm going to have a sip of my coffee. I'll tell you what, just to break this section up a little bit, I'm going to start a new recording actually. Sorry about that delay. So we bit the bullet and got a Disney Plus subscription, and I watched Free Solo the other day, and I think my pulse rate was up to like at least 130 just sitting there watching at the end. It's kind of crazy. So if you guys need a little cardio without wanting to move anywhere, Free Solo might be a good option for you. I'm taking any other good movie recommendations if you want to throw those out in the chat feature. Oops. Okay. Where's my... Okay. Okay, I'm going to assume you guys can see the slideshow for the intervertebral discs and nerve roots. And I'm going to hit record here.
Looks good.
All right, thank you for the confirmation there. Can you see me still or no?
Yes.
Okay. Could you see me that whole time?
Yes.
Okay. Let me know if you want me to turn that feature off. I thought maybe you were just seeing the screen there, but I'll leave it running so you can kind of, maybe I'll just use more hand gestures this time knowing that it's going. So, all right. Okay, so we're going to hit record. And away we go. All right, team. Let's keep rolling here with the intervertebral discs and the nerve roots. This section is kind of fun. So just to give you a little bit of a heads up of what we're doing next, intervertebral discs is probably about a 2-hour chunk of material, maybe give or take, depending on how long I toggle between screens here. And then also the vascular section is the final set of notes that we'll use, and that's probably another 2-hour chunk of time. And so we're really kind of close to wrapping up the term here. So we'll handily finish up by next week, and hopefully, get you wrapped up. The section here on the intervertebral disc is kind of a little bit of review, but then we're going to get in some nomenclature. So well, here we go. We'll just do it rather than talk about it. So this is information that you guys already know about, right? There's 23 intervertebral discs in the typical patient spine and 26 osseous structures. All right. So the first one being again at C23. And then moving on down. That's one thing I'll just mention right now. You'll hear different people say different things, but I'm pretty adamant about when you're talking about a joint space, especially in the spine, you should give two levels. You should always say C23 or C34. You'll hear Dr. Egebrecht in the future talk about the C2 disc, and that one's pretty easy because C2 is only next to one other disc segment, C23. But if you say the C5 disc, to me, it's not really clear. Are you talking about C45 or C56? And so same thing goes with IVFs. When you're talking about a space or a disc space, I would encourage you guys to provide 2 levels, no matter what else you hear. It's just the best way to be clear about that. Okay, and so the last one is going to be down at L5S1 in the typical spine, and of course you've seen a couple of transitional segments in the program just this morning, so you know that it's quite variable. Okay, so the 2 main components of the intervertebral disc, and you've heard these terms before, but the annulus fibrosus and the nucleus pulposus. And what you can see in this situation here, I know it's a very basic diagram, but you can see these concentric fibers extending circumferentially around the entirety of the disc with multiple layers here. That's your annulus fibrosus, right? So kind of tough fiber cartilage woven around in multiple concentric rings to hold everything together. And then the more, the part that is not pictured here is the more water containing nucleus pulposus. So what we don't always really think about is the fact that the vertebral body end plates really are part of the disc, or the disc is part of the vertebra. Obviously there's the bone and then there's the cartilage, but especially early on in adolescence, childhood and adolescence, these end plates really are the top and the bottom of the disc itself. Think about like an Oreo or something like that without the cracker part. You just have the filling. To complete the thing, you need your top, and that's a terrible analogy. All right, top and bottom of your Oreo cookie here for the whole thing. So you can see these fibers actually blend into that vertebral body end plate. And as you guys know, the end plates have 2 of our 9 secondary growth centers. And so they're cartilaginous, and they just kind of all blend together here. All right. So just a quick little picture here from Netter. And actually we'll get to a live picture here. There's a little bit better, kind of a fresh animal specimen here. But they look almost the same for us as well. So you can see these concentric layers. You can almost peel them apart. Which is important to know. These layers can separate And so we'll talk about that as it relates to disc herniations in just a little bit. Look how water containing that thing is. It just looks like just gelatinous, like, yeah, anyway, hence the kind of the jelly donut analogy when docs are talking about disc herniations. They describe it that way. I would encourage you to find a better way or a different way to talk about disc herniations with your patients than thinking about it as a jelly donut with the filling squishing out, okay? So what do the discs do for us? How do they support movement through space, and how do they handle all the mechanical stresses that are applied to our spine? That's the next set of slides here. Sorry, it's my dog is joining me here. This is Cooper. Oops, you got to be quiet, bud. Okay. I'll introduce him at the break. The discs here are going to help distribute this force in a number of ways. So these three, there's three slides coming up here, and it's really kind of overkill, I think. So don't overthink it. There's a few words here to describe what I'm about to say here. So picture just one disc at a time in the spine, and it could be any level. As you place a compressive force onto that disc, whether or not you're walking through space and your head is kind of moving up and down. I'm actually sitting on a ball right now, and you can, so that's going to help distribute some of that force. But as you compress, as pressure kind of comes down across the bony portion of the vertebral body, it compresses that nucleus pulposus, and the pressure goes up. So the pressure gradient inside the disc and the nucleus goes up, and that in turn is going to push out on those annular fibers. So they're going to start to expand. That's what this image right here is showing you here. Because they're concentric and they're all tied together, they'll expand a little bit, all right, but the force is going to be transmitted circumferentially around that thing. And then at some point in time, that pressure is going to equalize, right? So the annulus will go only so far before it actually starts to rebound a little bit and push back on that nucleus pulposus. And so you're going to have this pressure kind of go out and then come back in and equalize over time. And of course, you can see this is not just happening at one level. This pressure is going to be put down through the next vertebral level onto the next disc, so on and so forth. And so again, it's not going to start at C23 and work its way up and down the chain. This is something that's constantly happening at all times, where you have an increased pressure, expands, rebounds, and forces kind of move about that way. Think about it kind of as if you've got a basketball and it's kind of deflated. It's kind of squishy a little bit. You can push in on that thing. If you pump air into that basketball, the inside chamber is going to expand, and the outer layer is going to kind of get nice and taut. But at a certain point in time, it's not going to go anymore, and then you can bounce it. So pressure kind of goes back and forth inside and outside these discs. So we need this to happen in order to stay healthy, right, and keep moving in a proper way. And there's a problem that happens now if we lose the hydration, and so we are dependent upon our discs holding on to that water as much as possible in order for them, to transfer the forces in a healthy way. And if we start to lose that water, you can imagine that disc is not going to be able to handle these forces in as efficient of a manner as possible as it used to, and that's going to allow for a little bit of extra unwanted movement at the discovertebral level. All right. Just to get into a little bit of histology, I'll leave this for Histo 1 and Histo 2 for you guys. But one thing to maybe consider, like how do we maintain this hydration, or why is there water where it is the fact that the nucleus pulposus is just chock full of proteoglycans, okay? And so you have these large protein molecules with a bunch of glycosaminoglycans attached, okay? And they're hydrophilic, right? So they like to hold on to water molecules, and that's kind of how we maintain that level of hydration. If we start to break down the cartilage fibers, it's not going to hold on to that water as efficiently. All right, so you guys can you'll be diving into all the different glycosaminoglycans, names and nags and stuff like that. I forget the abbreviations, so check that out. And of course, this leads to the big question of, can we consume glucosamine supplementation in order to help maintain this level of hydration? And I think the research is kind of out on that. I don't know that taking a high dose of glucosamine is going to help your discs maintain, because I don't think we always get to choose where we put this, where the supplement goes, right? So that's something to kind of keep an eye out for with in regards to supplementation. You're certainly going to get questions from your patients in that regard. All right. And so I think we already alluded to this here. So make sure I think this is not a medical term per se. To desiccate is to dry up, whether or not you're, preserving, beef jerky or something like that, or drying mushrooms, or it's happening in our bodies. So as we age, we naturally tend to, desiccate, right? Our bodies don't hold on to water as much. This is where you can help your patients, do their best to adopt, healthy behaviors, right? Proper movement, I think, is going to be important for getting water to and from different places, but certain bad habits, right? So smoking is one of the biggest things you can do to desiccate some of the tissues of your body, especially of the cardiovascular system, pulmonary system, of course, that goes without saying. Desiccation is going to be another thing that we're going to try to stave off, but it is obviously part of our natural progression, at least until AI can come in and make us pseudo bionic and keep the body going. I'm not sure that's going to happen anytime too soon. Okay, so if we have anything that alter those stresses here, we're going to start to get disc degeneration. Okay, so that's just a little bit of the anatomy of the disc in a nutshell and how it handles those biomechanical forces. This next phase that we're going to talk about here is the nomenclature of disc herniations, right? So I know that gets people excited when you hear the word nomenclature. You got to study nomenclature of disc herniation. So I imagine you guys are going to want to think about this the rest of the day here. So no, this word is like an absolute turnoff, but we're going to dive into it. And it's going to be okay. And so historically, it used to be the Wild West when it came to describing disc herniations. Somebody would say herniation, somebody else would say protrusion, somebody would say slip disc, all these different things, and there was no standard for what anybody was talking about. So this has probably been a couple decades now. A group of some authoritative people got together and published a set of this nomenclature to be used, and it's been pretty widely adopted. And so we should be pretty much on the same page. Of course, everybody's heard this term before or heard the phrase, I've got a slipped disc, and you'll hear patients say that to you. I don't know that you should say that to them, because it kind of implies like the disc goes shooting out, and it just doesn't really do that per se, although you can have some dramatic disc herniations. All right. Okay, so these are the terms that you just want to be familiar with here. So we're going to talk a little bit about the difference between a disc bulge, and then a disc herniation has a couple of subtypes. Okay, and then there's a special feature called a annular tear or a diffuse annular tear. Okay. So when somebody says they have a bulged disc, or if you say my patient has a disc bulge, of course, this is something that you're going to get from an MRI. If you suspect it clinically and you feel like an MRI would help change the way your treatment of this patient goes, then that's the imaging modality of choice over CT in regards to disc herniations. You'll be prepared to read the report, get the findings back, and help your patient navigate through the images. So when it comes to a disc bulge, the basic definition here is that the area of involvement, the bad part of the disc, so to speak, is going to be more than 25% of the circumference. Oh, there's another problem there. All right, so this is not going to be a big deal, but maybe just swap out diameter with circumference, if you will. There we go. All right, so what are we talking about here? And again, don't worry about the diagrams. They're just meant to kind of give you a little bit of a visualization of this feature, and I'll kind of break it down as we go. But as you have, I'm going to draw up here actually. So if I have my disc, this is looking top down. That's a terrible. Just imagine it's perfectly round. If I divide this thing into quadrants, oh boy. Okay, sorry guys. Okay, I'm just going to use this quadrant right up here. So imagine you've got this normal disc surface. If the disc herniation, so to speak, I'm using that term loosely here, extends beyond 25%. Okay, that's when we're going to use that term disc bulge. Okay, if it's less than 25%, that's when we're going to use herniation. So more than 25% of that total circumference of involvement, you've got a disc bulge on your hands. If it's just like I've drawn here, kind of part way, but not the whole thing, we'll describe that as a asymmetrical disc bulge. However, if the disc bulge itself has gone the entirety of it, I don't know if this is going to help if I draw another one or not. No, that's terrible. All right, so that'll be my mission this next week, is to see if I can fix that. But you can imagine if the thing is bulged out around the entire circumference, it's just kind of flattened and pancaked out, then you can use the term diffuse annular bulge. All right, so bottom line though, the disc bulge is going to be more than 25% of the entire ring. Okay, if it's less, then you're going to use the term disc herniation. Just make sure I'm there. All right, so now we're on to disc herniations here. And there's two subtypes. So when you're reading your patient's MRI report, all right, they've got some radicular symptoms, maybe it's not responding to care, you're concerned about it, and you want to see exactly what's going on, send them out for an MRI. And when it comes back, you might hear something about the fact that there's a disc herniation with in parenthesis, protrusion or extrusion. All right, so those are the two subtypes of disc herniation here. So just to break this down a little bit, disc protrusion, of course, we're less than 25% of the circumference. So what I've tried to do in this illustration here is to take you, if you look at the entirety of the circumference, where you have normal annulus fibrosis right about here up until about this point, you can start to see the annulus is raised out. It's pushed out a little bit. Okay, so I'm going to say this is the start on one side, and this is the other side where the annulus fibrosis has extended out beyond its normal base, so to speak. Okay, so this is the base of the disc herniation. And what separates protrusion from extrusion is the fact that the base is wider than the outward extent. All right, so if you were to think about this like a hill, if we were looking at this in a different projection, here we go again, I'm going to try and draw. There we go, there's our hill. You can see how the base of this hill from here to here is one distance, and then the height of that hill is another distance right here. And so again, if we have a disc herniation, we have a problem of the disc, which is less than 25% of the circumference, and then we divide that down into herniation, a herniation protrusion or a herniation extrusion, and the protrusion has a wider base than its outward extent. Okay. Oftentimes, the annulus fibrosis is not completely torn. This is not part of the definition, by the way, though. So don't worry about whether or not a disc herniation, as you're seeing it drawn here, you're seeing this nucleus pulposus kind of tear through multiple fibers, maybe just not the entirety of it. That is typical of a disc protrusion, but it's not part of the definition. It's not a requirement. Some disc protrusions have nucleus pulposus that leaks out. Other extrusions, extruded discs, also might be intact. Okay, and oftentimes it doesn't happen this dramatically, where you have this massive rupture of the disc fibers. You can have a partial tear through one layer so you can have a concentric ring that is intact while the nucleus is still getting through it, if it's not completely torn. So this diagram is a little bit overly dramatic, but the basic thing that I want you to hang on to is the fact that a disc protrusion has a wider base than its outward extent. Okay, so what I've tried to do here is just show you, and again, maybe it's not the best way to go here, but if you can imagine the base of the disc right about here, okay, going across there, where it starts to rise up, okay, it only has, this is the area of involvement, but it actually extends out quite a ways. That's going to be classified as an extrusion. So the outward extent is taller or more dramatic than the actual base. So it's a little bit more of like a polyp going out, if you will. And that's the basic difference. Oftentimes extrusions do have nucleus pulposus that is free and through the entirety of the annulus fibrosis here. Not always. It can be contained by the annulus. Again, that's not part of the absolute definition. But for this reason, we'll talk a little bit about pain in just a little bit, but oftentimes disc extrusions do have exposed nucleus pulposus that has gone outside the confines of the annulus fibrosis. And then finally, sequestered disc fragment is another component, and you'll almost invariably get these with a disc, only with a disc extrusion, not generally seen with disc protrusions. But here again, I would just treat it as a separate thing. So for the purpose of the exam number 3, you're going to want to be able to say, okay, this disc is a protruded disc if it has a wider outward extent versus definition for an extrusion, and then here's a separate definition by itself here. A sequestered disc fragment has broken away. I know this little glob is still kind of close to the parent nucleus right here, but picture it as a separate piece. This is kind of like your lava lamp. And so, does anybody have any lava lamps out there? I used to have one when I was in high school, and somehow I don't have it anymore. I think they're kind of making a comeback, maybe not. So let me know about that. But in any case, as you plug your lava lamp in, right, it starts to kind of bulge a little bit, and then finally it heats up enough for one of those little pieces to break away. That's your sequestered disk fragment right there. Okay. Problem with a sequestered disk, by the way, is that it can go anywhere. So it may stay right here, but it can track up the central canal or the spinal canal, or it can go down. And so in this case, you can get some really kind of unclear clinical findings. You might think that their disc herniation is at L3-4, because the distribution of their radicular symptoms. Yet when you get the MRI back, you can see that, oh wait, it's the disc at L4-5, and this little piece has traveled up the spinal canal. All right, the last one we're going to talk about here is our annular fissure. Okay, so think about this as a tearing through the annulus fibrosus itself, and so these tears tend to go circumferentially around the disc itself. So instead of having a rupture, right? So we're not going to cut, straight down through the entire width of the annulus fibrosus here. But imagine one layer has a tiny little tear in it. So some nucleus material leaks into the layers in between the annulus fibrosus. It can continue to kind of go through multiple layers like you're seeing here, or it can actually track along the layers. Okay, and so what we're looking for on the MRI is these white dots, right? So in theory, our nucleus pulposus is water containing, and so on an MRI, this is not something we've talked about a whole bunch here, but let me just back up and talk a little bit about MRI here. Obviously, we're not looking at a CT scan. We're looking at MRI because the cortical bone is black. The other thing that you're going to do, we'll talk more about this in ScaleRed 2, is looking at the water density. So you can see in the spinal canal here, we've got brighter signal intensity. So we know that there's a lot of CSF, which contains water, in this region. And so MRI is broken down into what's called a T1 and a T2. And those stand for tau, not time. And all you need to know right now, or this may be of interest to you, is that water is dark on a T1 weighted image and water is bright on a T2 weighted image. And so what we're looking at here is a T2 weighted MRI. And what's interesting is this little tiny bright dot right at the back of the disc. And so you guys can see these disc herniations, I think L4-5 most dramatically, a little bit here at L3-4. The interesting thing about the annular tears, all right, is that, so what we're talking about, this high intensity zone, by the way, sorry to flip back and forth there. A high intensity zone is the finding on the MRI, where you have this high intense zone kind of surrounded by the disc material here. So initial research came out that supported this idea that this is a cause of back pain. And we've always been trying to find like the imaging finding that will tell us for sure whether or not that's causing our patient's back pain or not. And unfortunately, that research didn't really hold up. And so at first, when this came out, one could assume, or clinicians did assume, that you could look at this and say, wow, that looks like a big disc herniation, right? However, that may not be causing your patient's pain. We can't assume that the pain is coming from this disc herniation here or this one. But the idea initially was that, wait a minute, forget this disc. The high intensity zone has a higher incidence, or a correlation rather, with actual symptoms. And so maybe the L3-4 disc is the problem, or you can see another one here at L5-S1, as opposed to the big kind of look at me disc herniation that we're seeing at L4-5. Again, research has kind of gone back and forth, and there's newer research out now looking at MR spectroscopy and seeing if there's a higher correlation with findings on that as opposed to plain MR. So that's something that will be on the scope of this class here today. So let me just keep an eye on the clock here. I guess just to kind of stick with our normal routine, if you guys don't mind, this might be a good place to just hit the pause button. And if you guys want to move around a little bit or chat, I'm just going to hit pause on the recording here. Stop sharing. Just kind of hitting the pause button, and we'll continue to talk a little bit about this, and then we'll switch gears and go into a little bit just of a exam 2 review for the latter part. So any questions that you guys have? Trying to get my chat feature up here.
For those extrusions and sequestered disc fragments, is there an annulus fracture in those too?
Can you say the first part one more time?
For the extrusions and sequestered disc fragments,
Yep.
is there an actual annular tear in those, or is it just how it's drawn?
Yeah, well, primarily it is just how it's drawn. Now, for a sequestered disc, there is definitely a tear through the annulus, but the problem with that diagram is that it would leave you to believe that all of the layers are completely torn, and so let me I'll try this out with using my hands here. There's a difference between a full thickness tear and a complete rupture, right? When we're talking about any like ligament or tendon. And so if this is my ligament right here, so I've got a ligament here and I completely sever it, right? That's a rupture. But think about it this way: what's happening to the nucleus pulposus? If this is my annulus fibrosus right here, this is top, this is the backside. If the nucleus pulposus goes through these layers, like so, that is a full thickness tear, but the annulus has not ruptured, right? So it's kind of weaving its way in between these little fissures and cracks and tears, and can get out. So that's one way in which you can have disc material that's extruded outside the annulus fibrosus without an actual complete rupture of the annulus fibrosus. So I don't know if that quite answers it, but definitely with a sequestered disc fragment, you have free-floating nucleus pulposus. And I would say with most extruded discs, I mean, the name implies that you have an extrusion of this nuclear material outside the confines of the annulus. It doesn't have to happen that way. You can have a disc extrusion that really kind of pushes out where there still is a fully intact annulus fibrosus that's containing that nuclear material, but it's more common to have free exposed nucleus pulposus in that case. Hopefully that helps.
Okay, cool.
Good. Cool. All right. Well, I'm going to hit pause. We'll come back in about 10 minutes. Is that okay for you guys? And we'll go from there. So let's see. I've got 8:51. All right. Very good. Well, I'll come back at 9 o'clock. I'll start with I've got a kind of an interesting case for you guys to see. Some non-spinal stuff. So, all right. See you in a minute. Oops. Bending across their third proximal phalanx here, unfortunately for them. But the good news is that it's minimally displaced. There's really no angulation. There's no rotation. I couldn't see it very well in the lateral view, nor the oblique view. So the way they turned the foot, it just kind of disappeared. So it's kind of an interesting case for you guys, I would say, just from a standpoint of mock effect. So you can see kind of what would be like the ball of the foot, all the padded soft tissue down there. That's what's creating this shadow cutting across the toes here. Kind of lose the definition of the spacing between the second and third there. It's not uncommon otherwise to have a little bit of fusion of the soft tissues here, but definitely a fracture, just kind of faintly visualized right here. So under normal circumstances, my report would say something like, referral to an orthopedic specialist is recommended. In Minnesota, we don't treat fractures. It's beyond our scope of practice. And but I think we all know, well, you guys will if you don't already, like some of these little toe fractures, they're going to heal just fine. You just want to support the patient in the interim. So I modified my report, however, in this case to basically not recommend going and seeing an ortho. There's really considering, the demand on the healthcare system right now and or the risk that you might take going into a bigger clinic where there might be other people who are sick. This is one of these things where we can manage this at home. So I would say crutches would be good, just to avoid having the patient have to toe out. So if any of you have broken a little toe before, it hurts like crazy. You can kind of hobble around, but what you end up doing is turning your foot in such a way that pretty soon your ankle or your knee or your hip or your back or all of it starts to really kind of pay the price for walking in an abnormal way. So walking boot would be just fine. Anyway, thought I'd share that case with you guys. Any other questions about that? Otherwise, we'll press on. I want to talk a little bit about the, we'll spend a couple more minutes talking about the issues of disc herniations and pain. And then we'll switch gears and move into the exam 2 review.
Did she injure her fourth toe as well?
Yeah. So, are you looking at the curvature?
Yep.
Yeah. So yeah, the report or the history was basically pain at the 3rd and 4th digits, and but on the phone I was able to clarify that the parent was noticing that there was a little a visual deformity of her 3rd toe, or so they thought. They did not think that there was a visual deformity. So in this case, I think it's just a function of the arch. As the toe is, setting down there, and you can probably check out your own toes too. It's just the way that the toe is curled, just so it's accentuated on the projection here. So a little bit of an archway with the padding on the ball of the foot there, causing that toe to turn in. So I don't think it's otherwise dislocated. Okay. Good question. Any other questions about the findings here? Pretty good joint spacing, sesamoid bone here, and yeah, that's about it. All right, I am going to figure out how to switch back to my Okay, you guys see the disc herniation slideshow again? I'm assuming. Let me know if you don't. Okay, and we're going to continue with the recording here. Okay, so just to kind of not to keep you in suspense here, I'm not gonna give you the answer because I don't have it. So why do disc herniations hurt? Sometimes they do, sometimes they don't. And this is like the big question that we're going to struggle with as healthcare providers in several different facets. Like why do our patients hurt, right? Well, you fall down, you break your toe. We can be pretty confident that is the source of pain right there. There's a bunch of nociceptors that are saying, you shouldn't do that, and your body is trying to heal it up. And so that's pretty obvious. But we can't assume that disc herniations hurt. And so one thing I just want to emphasize here is that when you look at radiographs or MRIs or imaging of your patient, you cannot assign pain to the things that you're seeing in most cases, okay, barring fractures or clear and obvious pathology that's occurring here. And so a couple of theories that have kind of gone back and forth, and I think we're still learning more about this is so obviously mechanical pressure on a nerve root, right? If you have a big and sudden and acute disc herniation that compresses a nerve root, that generally will hurt and or cause neurological deficits. So think about something like a cauda equina syndrome. This is a patient who might be losing bowel bladder function, acute rapid onset of pain following trauma. You'll learn how to screen for that. And if those patients show up in your office, that's a medical emergency. They need to go to the emergency room, okay? But most of our patients are going to be those who have maybe new onset of pain, or maybe it's chronic, it's ongoing, it's back and forth, they have numbness and radiation into their legs. Is that caused by the disc herniation? It would be really nice to if the answer was yes, if we knew for sure. But the problem is, as you can see in this diagram here, here's just an illustration of this nucleus pulposus that's kind of pushing through here right in the IVF, and it's compressing this nerve root, right? Well, the problem is, if this is whatever side we want to call this, I guess this is truly the patient's right side, there will be plenty of times in your practice career where you ordered the MRI, the patient's got radiculopathy on their right side, and it corresponds to the L4 nerve root or something like that, yet the disc herniation is on the other side. Okay, and so the disc herniation may be a complete red herring, meaning it's kind of a flashy, attention-grabbing thing, but it doesn't actually have anything to do with your patient's symptoms. Okay, another theory here is that when we do experience tears through the annulus fibrosus, there's a bit of a chemical irritation or an inflammatory process, right? And the theory here is that when we're developing, right, if you go way back to the embryo stage, right, the notochord is what becomes this nucleus pulposus, and it gets closed off. So this goes back to the sclerotomes, right? You got the medial migration, caudal cephalad migration. Sorry to do this over the camera here. And as the cephalad and caudal pieces are separating to go to that intersegmental vertebra, right, that notochord is receding, right? It's no longer needed for that structure, and it goes into the nucleus pulposus. And then again, during that cephalad caudal migration, some of those sclerotomes will basically drop a curtain around that nucleus pulposus and become the annulus. Well, this all happens before our immune system develops. All right, so our nucleus pulposus, if you've never had any sort of herniation or tear or any nucleus getting out, your body doesn't recognize the nucleus as self. And so when we have this tear, this can produce this big autoimmune response, essentially. This is cascade of interleukins and other inflammatory mediators in order to go and attack this nucleus pulposus. The good news is that when you do have free floating nucleus pulposus, because of that inflammatory response, that material can actually get resorbed, basically get taken care of. Unlike a more of an annular bulge or a disc protrusion, where the nucleus is still entirely contained in most cases, those can persist and cause problems for a while if they are truly the pain generator for your patient. All right, so that was a bit of a long-winded way to say that. Bottom line is we don't image pain. We can't make assumptions in most cases, and there's a couple theories out there between mechanical pressure and an inflammatory response, but more research is being done with different imaging modalities as they develop. So when we look at this patient's MRI, if this is the patient you just sent off, maybe you've been treating them for a little while, but you sent them off for an MRI and you get this back and you say, oh, yep, there we go. That's the disc herniation. You can't really do that. Okay, we can't know that this patient has back pain. So you can have a perfect looking image, X-ray, has no disc degeneration whatsoever, yet that patient has a lot of pain. Contrast that with somebody who has really bad degeneration. They'll have some good days and some bad days. And so again, try not to make assumptions based on pain. Always, go back to the clinical presentation for your patient here. All right. So our next section here on nerve roots, I'll just do a little bit of an introduction here, and then we'll hit pause there. And so what you're going to be challenged to do here, not just on exam number 3, but in actual practice, right, is to understand what nerve roots exit which levels, right? So that's question 1 of 2. So there's 2 components here. What nerve root exits any given level? So you want to be able to answer that question definitively. And then what nerve root is affected by disc herniation at a given level? All right, and you want to treat those 2 topics separately, even though they kind of coalesce at several segments here. And so the reason why this is a little bit more complicated than it really ought to be is the fact that we've got this little C8 nerve root, right? So as you guys know, we've got 7 cervical vertebrae, 12 thoracic, 5 lumbars, and our nerve roots, kind of coincide with that. So for example, in the cervical spine, what you want to be able to do is say, okay, at the level of C4 and C5, you've got the C4-5 IVF, right? So what nerve root is in the C4-5 IVF? That would be a perfectly, that's a test question that you can expect to have on the final, on exam number 3, okay? And it should be pretty straightforward for you guys. So imagine in the cervical spine, if you are C4, right, you're the C4 vertebral body, you got your TPs at 60 degrees of the sagittal plane, right, 15 degrees down, and you happen to be kind of U-shaped or gutter-shaped. Well, if you're C4, you're going to cradle and hold your own C4 nerve root, all right? If you're C4, you're not going to hold C3 or C5. That's somebody else's job, right? So C4 holds onto its own C4 nerve root, and that nerve root is cradled in that TP, right, above the pedicle, okay, which would put it into the C3-4 IVF. All right, so you just want to be able to break it down. So at C3-4, you have the C4 nerve root. At C5-6, the C6 nerve root exists there, okay? And what we want to be able to do is answer those questions anywhere throughout the spine. The problem is the pattern changes, right? So at C5-6, you've got C6, so you could just think about it as the lower level, right? But when we get down into the thoracic spine here now, let's instead of C5-6 with the C6 nerve root, okay, let's think about T5-6. So at T5-6, you're now going to have the T5 nerve root. And the reason is this extra nerve root, C8, okay, is going to push the whole pattern down a little bit, okay? So C4-5, C5 nerve root, C5-6, C6 nerve root. But then at C7-T1, you've got C8. So T1 has to wait, right? So now at T1-2, that's where the T1 nerve root is going to exit, okay? So at L4-5, L4, T4-5, T4. At C4-5, C5. Okay, so you can see how the system is a little bit different there. So I'm going to leave that alone. The next question that you have to answer is, okay, if you have a disc herniation at a given level, okay, what nerve root is going to be affected? And so to answer that question, you just have to identify which nerve root is closest to that level, and it's going to get a little bit wonky in the lumbar spine. In the cervical spine and the thoracic spine, it's pretty straightforward, right? So if you have a disc herniation at C4-5 here, well, you simply just say, okay, between C4 and C5, you've got the C4-5 disc, you've got the C4-5 IVF, and if you know that the C5 nerve root exits at that IVF, a disc herniation of C4-5 will most likely affect the C5 nerve root, if anything, okay? So at T4-5, same thing holds. You get T4, you get T5. A T4-5 disc herniation is going to affect that adjacent exiting nerve. It just so happens, though, that the exiting nerve is T4, okay? So whichever nerve root exits that given IVF in the cervical and the thoracic spine, that's the nerve root that will be affected by an adjacent disc herniation. The pattern changes a little bit in the lumbar spine because of the cauda equina. So that's what we're going to get into next week. All right. Any questions about that? Did I make it entirely confusing for everybody?
Good, but could you just, what is?
Oh yeah, well, nothing really. It's now, yeah, because the good question. So C8 is just simply coming straight out of that IVF at C7-T1. And I mean, so you could think about it as being cradled, so to speak, by the T1 TP. Granted, we no longer have those unique shapes that we have in the cervical spine. So yeah, of course, these are kind of angled down and they're sloped down to kind of get from the neck into the brachial plexus and the shoulders here. Here in the once we're in the thoracic cage, we don't need that extra protection, right? So the TPs are doing their thing, and then there's just the IVF, and the nerve roots exit straight out from that area.
Is that a rib coming off C7?
Yeah. I wish I should probably find a different one. Yep, good question here. So Netter has drawn in a cervical rib in this case, and so this diagram is meant to show the brachial plexus, and in this case, you can see how a cervical rib could impact the brachial plexus. Kind of going back to the muscle section regarding our scalings. You have your anterior and middle scaling, right? And so muscle hypertonicity can compress that brachial plexus. Here's another different way in which a patient could develop thoracic outlet syndrome, TOS, is with a large cervical rib here. So yeah, I would just, for the purpose of this, I would say just try to ignore it, but it's a good pickup, the fact that C7 has an extra rib right here. All right. So I think in this case, I'm going to just hit pause real quick. Well, I'm just going to do it. I'm going to stop that recording and start a new one. That way, hopefully, it'll just be broken up into chunks for you guys in case you just want to come back and see the review or anything else like that. Just do a quick, give me 1 second here. Okay, we have finished the intro to the discs, and we'll continue that next week. And at this point in time, what I'd like to do is just do a little bit of a exam 2 review. And what I have prepared here is just a handful of slides, nothing too huge, with various exam style questions that you might be able to, or might expect to see on exam number 2 here. So just to recap, once again, we're starting with the material from the composition of bone section. That includes then scoliosis, and then anatomy of the pelvis, and then finally the ligaments. Historically speaking, ligaments tends to kind of dominate the. It's not going to be like the whole test or anything like that, but I think most of the other stuff is slightly more straightforward. Ligaments tend to be a little bit more intimidating until you get in there and you kind of break them down into different sections there. So I guess number 1, do you guys have any questions right off the bat here regarding the exam? It's going to be the same style as exam number 1, mostly new material. No more than 25% of the exam will come from previous material, but things to kind of make sure you go back and shore up are your facet joints. And so making sure that you know that the facet joints relative to the horizontal plane are 45 in the cervical spine, 60 degrees in the thoracic spine, right, and then 90 degrees in the lumbar spine. And then the second part of that is to know, okay, do they angle any particular direction? So the answer to that is no in the cervical spine, right? They're just 45 degrees. If these are representing my superior facets here. In the thoracic spine, the superior facets do angle out, recall, at 20 degrees. So therefore, the inferior facets are medial 20 degrees. Something unique about that is down at T12L1, where the inferior facets, instead of medial 20 degrees as they face, like the rest of the thoracic spine, they are turned entirely out laterally, almost entirely laterally, and they adopt more of a lumbar type inferior facet. And so those superior facets in the upper lumbar spine face very medial, while the inferior facets face very, very lateral. Okay. Other than that, going way back, just make sure you understand the difference between, like, somites give rise to sclerotomes, dermatomes, myotomes, and the sclerotomes, merge to develop a segmental vertebra, and then they divide to do the intersegmental vertebra. And I don't know, I think you guys are, it should be pretty straightforward. So, all right, so at any point in time, feel free to chime in here. I guess I've never done this remotely before, so let me make sure I can see my chat screen here. Sorry about that. Oh, I'm sorry. Good questions here. These slides are not on Moodle, but I will put them on Moodle. So beyond just the lecture recording here, I'll put those in there. Okay. So I don't know how you guys want to do it. Do you want me to just give you a couple seconds? Obviously, you've been looking at the screen here for a little while now, so you probably have the answer down. I don't know if you guys want to do a race to the chat feature or just shout it out. Could get chaotic, I suppose. So, all right, let's just go here. So which of the following ligaments creates a border of that greater sciatic foramen? So you have to kind of know 2 parts here. I'll show you a picture in just a little bit here, but there's two options that should make you think about it. Ilioinguinal, not in that region whatsoever. Iliolumbar, remember, going from the L5 TP, so you can get rid of those right away. Sacrotuberous and sacrospinous are both in that area, but it's our sacrospinous that's going to be basically the horizontal divider between the greater and the lesser sciatic notch. Sacrotuberous is going to help form kind of the lower border of the lesser sciatic foramen. All right, so in this case here, say C, sacrospinous is what we want to go with. All right, so what spinal motion is prevented by the PLL? This one's pretty straightforward, but I just want to make sure, don't overthink these questions on the exam. So basically, like I mentioned before, anything in front of the vertebral body is going to help prevent too much extension, right? It's going to pull my vertebra back from going too far into extension. Anything behind the vertebral body is going to help prevent too much flexion. So PLL is going to check flexion of the spine along with anything else behind it, like the ligamentum flavum, interspinous, supraspinous ligaments, all those things there. All right. Hyperextension injury of the cervical spine will most likely damage which of the following ligaments? So hyperextension, cervical spine. So if the individual patient is going to have a whiplash style injury where their head gets pulled back, the tension is going to be applied in the front of the spine, right? So that should fit with the anterior longitudinal ligament. Okay. Which cell type is responsible for bone production? So 3 main cell types that you want to be able to kind of name and identify their function, right? And so in this case, we're going to look for osteoblast. And so osteoblasts build the bone, recall. Once and they do that by secreting osteoid. Once that osteoid kind of covers them up, sorry about the microphone there, they get covered in their own osteoid, and then a new layer of osteoblasts forms on top of that, and those osteoblasts that are covered up become osteocytes, right? So those are mature bone cells, definitely the most abundant bone cell in the system. But then osteoclasts are responsible for breaking down the bone. So you want to try to, our bodies obviously, try to get homeostasis between building and breaking down bone. When you have a fracture, both cells are going to play a role. The osteoclast will kind of clean up those broken fragments. So for example, that little toe fracture that we looked at in the other section, likely that fracture line will look more prominent 1 to 2 weeks from now. It'll look a little bit worse, in fact, if you go back and x-ray it, because those osteoclasts are going in there and cleaning up the fracture line itself, and that will make the fracture appear wider. And then the osteoblasts come in and just slop on new osteoid and try to patch it all together. All right. So which of the following ligaments connects the jugular process of the occiput to the transverse process of C1? So it's just kind of get your locations down, right? And so jugular process you need to know is kind of just medial to the mastoids on the base of that skull. So it's more lateral relative to the occiput and the skull, right? It's not in the anterior foramen magnum, it's not posterior. And so we should be looking at the lateral atlanto-occipital ligament as our main one here. All right. Idiopathic adolescent scoliosis is the most common type. What are the other 2 types of structural scoliosis? Okay. So I guess I'll just answer that. Normally I'd make you guys talk in class too, so feel free to chime in if you want to, but otherwise we're looking at congenital scoliosis. So those are individuals who have a hemivertebra, so to speak. Everybody, we'll say hi. Yeah. All right. I don't know if you guys can see him at all. This is Cooper, by the way. Since we're doing a review, it's a little more cash. I'll let him say hello. It's my little Australian cattle dog. He's a sweetheart, but he likes to stick his cold, wet nose on your bare hand when you least expect it. So that's problematic. Okay, so we got congenital scoliosis here, and what are we talking? Sorry, I got distracted here. Other 2 types. Okay, structural scoliosis. Thank you. Thank you very much. So neuromuscular, right? So things like patients who had previously had polio or cerebral palsy would be another cause that could contribute to that. So the difference between those, the congenitals are going to cause more of a focal, tight C-shaped curve as opposed to these long, broad, drawn-out curves that you might see in somebody with a neuromuscular underlying cause. All right, describe the Heuter-Volkmann principle. So let's spend a minute talking about this one here, and you want to be able to kind of make sure you keep Wolff's law and the Heuter-Volkmann principle kind of separate in your mind. They both kind of have to do with stress applied to different things, but they really otherwise don't have anything to do with each other per se. And so as you're thinking about this right now, again, there's going to be no fill in the blank on the exam, just to be absolutely clear. But you want to, if you can describe it like an open answer essay here, you'll be just fine with a multiple choice. So the Heuter-Volkmann principle has everything to do with growth plates. Okay, if your patient is a skeleton mature person with no growth plates, there's really no Heuter-Volkmann physics kind of applied to that patient's body, right? And so where we talked about this was in its relationship with scoliosis. And so bottom line is, if we compress a growth plate, it inhibits growth. If we put a tensile force across those growth plates, it may promote growth, okay? Whether or not we're talking about a femur, a tibia, or a vertebral body. But where we really care about this is in the vertebral bodies when we have curvature. And so a teenager with open growth plates, right? If they have scoliosis, there's going to be a greater amount of compressive stress on the concave side of that curve, okay? And so their growth plates may indeed, or in fact, grow asymmetrically, all right? So a little bit of scoliosis can cause more of a wedge-shaped vertebral body, which in turn can cause more scoliosis, which can cause more stress on the vertebral body, and so on and so forth. It's just kind of a catch-22, or not saying the right thing there, but kind of a slow, progressive thing that just kind of a vicious cycle that keeps feeding on itself. Okay, as opposed to Wolff's law, which is just compressive forces or mechanical stress, rather. So don't think about it in terms of compression or tensile, but Wolff's law has to do with increased mechanical stress on bone causes increased bone deposition versus decreased stress on bone causes decreased bone deposition. So in that scenario, maybe it's best to think about your patient who is in a leg cast or something like that, not putting any weight on a single leg. That limb will experience more localized osteoporosis. And then once they rehab and start walking on that thing again and pounding the pavement, increased bone deposition will occur. All right. Any questions about that? That was kind of a rambly answer, but I think you guys got it. So again, chime in if you have a question about what we're talking about in the slide or anything else. This is a good time to just feel free to bust in and fire away here with any questions you have. I guess this is more of a, yeah.
That Wolff's law you said was the one benefit of being overweight?
Yeah, exactly. Just by virtue of being a little bit on the bigger side, like for myself, for example, as I'm walking around, there will be naturally more mechanical stress on my bones, and so it's somewhat protective, as opposed to somebody that has a much more petite body frame. Again, everybody's physiology is unique, but yeah, yep. So patients with I guess I couldn't tell you what the stats are off the top of my head, but I would imagine that osteoporosis is a little bit more common in a patient who has a more petite body frame. Yep. Okay. All right. So just a recap thing here. These are more like FYI. Just understand that, as your ligaments get pulled, a little bit of stretch will cause, some injury here. Okay, so if you tweak your ankle, it can hurt for a little bit of time because you've had a micro trauma to it. A 25% stretch, of course, is potentially going to rupture it. We talked about how ligaments are, slow to heal, and they generally don't regain 100% integrity because of the poor blood supply. And as far as something unique about these is that there are quite a few proprioceptors in there that can help you with your rehabilitation of your patients. So, I guess, I don't have any other questions here, but just to kind of give you a couple of ways to go about preparing the information. When it comes to ligaments by themselves here, you've heard me say this before, but think about it in different zones, right? So as you're about to study, right? You guys have been studying, I'm sure. Maybe you'll ramp it up a little bit more today as you prepare for the exam tomorrow. But you can really break it down into these sections right here. So we got our upper cervicals, and then our spinal ligaments, and then the sacroiliac. So I know when you're about to dive into a big topic, it can be a little bit intimidating and kind of unmotivating, really, to kind of get started. But just kind of start by breaking it down into these pieces here. So you guys memorize these in class, and at this point in time, one thing I would do to practice studying here, if I can get my drawing feature to work somewhat okay, is to just draw. So again, you don't have to be a good artist like me to be good at drawing these things. But if you wanted to just give yourself some basic structures here, I'm not going to draw all these, but bear with me. There's a C2 with the dens, and these are my lateral masses, of course. Right, so tectorial membrane, that would be that thing. Actually, I kind of go in reverse. If we kind of go to the deepest one there, you're going to have foramen magnum here. So you have your apical ligament, right, going straight up, and then your alar ligaments kind of going out obliquely, like so. Oh boy, it's getting ugly. Transverse ligament, right, going from the medial aspect. So kind of, if this is something that helps you, just draw, but also maybe articulate either out loud or in your head what structures are where and which ligaments are positioned relative to other ones. Okay, so for example, these are all kind of on the same plane, but now the transverse ligament is behind that dens, right? And as you guys know, it has a superior component, which will be slightly posterior to that apical ligament, and an inferior component, which will go down to the body of C2 here. And then if we take one step back, we've got our tectorial membrane. So if we were to draw that in, that's going to fan from that mid portion of the C2 body on up there, and you can kind of fill in that whole thing. All right, and of course the PLL will be what continues on down to C2 there. So if that's something that helps you, you can draw it and then sign it and send it off to your relatives that you're talking to, whatnot. But I don't know. I find it helpful to draw. Of course, you have your pictures that are a lot better. But if you can draw it and see it visually, you'll be just fine. Okay. So there we go. Any questions about this here? If you were to look at this diagram, can you label these things? We haven't talked about all these, so these are just kind of general oblique ligaments that I don't, to the best of my knowledge, don't really have a specific name, but perhaps they do, and I'm just not aware of it, but we didn't cover those. So you can see kind of that cruciate form of the transverse ligament, but as the name would suggest, the main band here is going to be going across from the lateral masses. All right. Moving around back, of course, we had our posterior atlanto-occipitals and posterior atlanto-axial that's been cut away, and you're seeing the ligamentum flavum here. Moving around the lateral side, we have our lateral atlanto-occipital ligament here, and then you're seeing that posterior atlanto-occipital in a different projection as compared to up here where that vertebral artery passes through. Nuchal ligament back here. Unique thing about the nuchal ligament, of course, is it goes from that EOP all the way down to the C7 spinous process. So just recall that the supraspinous ligament is what goes the rest of the way down, but the supraspinous is not recognized in the cervical spine. You just have the nuchal ligament above the level of C7, right? We also kind of talked about these big three. So again, all three of these run from C2 down to the sacrum. ALL being in the front. PLL, just recall, the posterior longitudinal ligament is behind, posterior to the vertebral body, but otherwise you could describe it as being anterior in the spinal canal. Okay, so remember that ligamentum flavum is what's in the posterior aspect of the spinal canal. That's something that people might get tripped up on. And you have a whole bunch of those little ones, right? So the intertransverse here, articular capsules have those two layers, recall. The inner layer produces a synovial fluid rather. Interspinous ligament is between the spinous processes. And again, in the cervical spine, this will blend into the nuchal ligament. In the levels below C7, this is where we recognize the supraspinous ligament from here on down. Okay. We had a big list here, but I would say as far as the ligaments of the pelvis go, again, be able to list them. But if you can look at a diagram like this and kind of talk your way through without looking at the labels, you're going to be just fine. So, for example, here we have the ALL coming on down here. Okay, anterior sacrococcygeal ligaments right here, lateral ones right here. Your SI ligaments, there were quite a few of those, but in the front we just have the anterior SI ligament. If you were to peel that away, then you have that articular ligament that holds the actual articular surfaces together. And then if you just move posteriorly from there in multiple layers, that's where you're going to see that interosseous and then the posterior SI ligaments, long and short. And so that's what you're aiming for. If you can sit there and visualize that as you look at a diagram, you're going to be just fine, you guys. I guess this goes back to that earlier question between the greater sciatic foramen up here and the lesser down below. You can see how that sacrospinous ligament is what's going to kind of create the border, the lower border of the greater sciatic notch, perhaps the upper border of the lesser, and the sacrotuberous is what's going to create the kind of the inferior or posterior border of predominantly that lesser sciatic notch there. Yep, just another projection. I don't think there's anything otherwise that. Oh, the other thing regarding the exam, if you can look at all of these landmarks and describe, what's where. I think you guys are all going to be just fine with that. Any questions about osseous landmarks of the pelvis? Oh, I did find a better diagram. I'm going to swap this out in the ligament section. I think you might recall me saying that I couldn't find a diagram with the more superficial sacrococcygeal ligament, but here it is. All right, so Netter did draw this in. So again, as the PLL comes on down behind the vertebral bodies down to the sacrum, once we get down to the level of S5 going to the coccyx, we have that deep sacrococcygeal ligament. That's what would be the PLL, right? And then think about the superficial sacrococcygeal ligaments as what could be just essentially the posterior arch of that area, because there is no osseous arch there with that sacral hiatus at the level of S5. Okay. A couple other things just to keep in mind is that long posterior SI ligament here. So you got your long fibers here running more vertically down to the ischial tuberosity, and then your short fibers running more horizontally. All right, so you have your posterior sacral iliac ligaments, the long and the short. Okay, and it's that long posterior SI ligament that will blend into the sacrotuberous ligament that you're seeing right here. Okay, so again, you won't expect to see, I'm not going to like put an arrow right here and ask you to label that ligament on a diagram or anything like that. That would be too confusing where those fibers blend together. Yeah. Well.
Will there be any pictures on the test?
Yeah. Yep. There'll be some pictures. So I would kind of go at it both ways, right? So if you can label a picture and then describe it, So, for example. Well, I'm trying to think what would be a good description. Gosh, off the top of my head, I'm trying to think. So, so if you can label all these features here, but you could also maybe approach it this way. So when we are looking at these gluteal lines, right, you have your posterior, your anterior, and your inferior, or some people describe this as the middle gluteal line. You could say, well, the gluteus maximus muscle is posterior to the posterior gluteal line at the PSIS, or which of the following muscles is between the anterior gluteal line and the posterior gluteal line. So that's your glute medius. So they just kind of go in different arrays like so. But yeah, writing descriptive questions is rather tricky when it comes to the pelvic anatomy. We just don't have quite as many of those like fine details like we did in the spine with regards to, how do you describe the shape of the pedicle in this region versus that region or whatnot. So, yeah.
Can you talk about question count versus time restriction?
Oh yeah, good question. So we'll have an hour, so 60 minutes, and there will be about 40 to about 45, give or take a couple questions. I think you guys will have, no problem completing the exam in that amount of time. I think with exam 1, I dedicated like a 2-hour section of the class just to make sure everybody's feeling comfortable with it. And I know there's usually a handful of people that will take the majority of that time. But I think for exam 2 here, it's going to be pretty straightforward, and I haven't had any issues with people completing it during the 1-hour time or class session. So yeah, about 40, 45, give or take. Yeah.
And our final will be similar to that as well?
Yes. Yep. Yeah, as far as at this point in time, I think we're just going to continue on. We want to try to, I think for your sake, and well, everybody's sake, try to wrap up as many of the classes that we can. I know some of the more practical based classes are going to be a bit of a challenge, but yeah, same format. And truly think about the final as exam 3. It's not going to be a big behemoth of a final exam. It's just exam 3 with the main topics being muscles, discs, nerve roots, and the vascular supply of the spine, and that's a pretty straightforward section of notes there. Again, with some material coming from the previous topics, so no more than 25% will be cumulative. All right. Let's see. So we're at 9:43. So we wrapped up, I think, in an okay time there. I'll hang out for as long as you guys have. If you guys have any other questions, feel free to either type them in the chat function here or shout them out. Otherwise, I'll be around throughout the day. Again, you've got my cell phone. If you need a quick answer, that might be the best way to go. Feel free to send me an email, of course. But if you're studying along and you just need something quick, I'll generally be a little bit more responsive as long as I can if I'm free to a quick text. So feel free to use that function or that option, I should say. And otherwise, yeah, plan on taking the test. So by tomorrow morning, by 8 a.m., you should have the exam will be available to download. Again, I'm just kind of imploring to your best selves to take the exam as you would if we were all in L1 together. And so you shouldn't be using your cell phone, shouldn't be using your notes, shouldn't be taking it with anybody else. It's not going to serve you in the long run on boards or life, really. So just kind of do your best and take it in good faith. That's all I ask. And so you'll have the password. I'll provide you with the resume code, and you should expect to start the exam right at 10 o'clock. And you'll have a time limit built into the exam itself. So please don't start it at like 9:30 or 9:45. Obviously, 9:58 is fine. 10:05 is fine, but we shouldn't stray too much from 10 o'clock. I'll have my phone on me, and I'll be watching the email during that time as well. And I'll also be able to monitor the exam on ExamSoft, and so I'll be able to kind of just see that everybody's moving through the exam at a reasonable way. And so if you have any glitches whatsoever, that would probably be the best time to fire off a text. So if you're not able to log in, or if something isn't working, just text me and we'll get it taken care of. So hopefully things haven't been too stressful. Otherwise, have you guys had quite a few other exams?
Just histo and anatomy.
Okay, histoanatomy, good deal. Did you guys do the practical exam for anatomy? And how did that go if you did?
He combined it with a lecture, so it was kind of one exam.
Okay, gotcha. Using the virtual body or virtual anatomy resources, I'm assuming?
A little bit of both. He went in the lab and took some pictures, and then he did the virtual body as well.
Okay, good. Yeah. Very good. I'm trying to think if there's anything else.
I have a question quick on scoliosis, if that's okay.
Yeah.
So just to clarify with the non-structural, so you said that will change with body positioning. So that could be a day-to-day based on day-to-day, like a diagnosis. Like you gave an example of someone, I think it was a student that walked into your office and he was leaning sideways. So you would consider that non-structural scoliosis, but the next day if he's standing upright again, then he wouldn't have it anymore.
Correct. Yep. Yeah, essentially, just like you described there. And so just to make sure, this might not be what you're wondering about, but so somebody with a non-structural scoliosis, they generally won't have a 20-degree curve one day and a 15-degree the next, and then a 20. So they're not walking around with scoliosis on a daily basis. But yeah, just to your point, it's somebody who, and in fact, this is where you would either palpate it or see it on an X-ray. You'd see a dramatic curve, yet the underlying cause is something different, whether or not it's back pain with intalgia or perhaps their legs are truly at a different length, and if you correct the limb length, that may alter the curve itself.
Sure. Okay. Thank you.
Yeah. All right. One quick question for you guys, if you don't mind. So last week I recorded the PowerPoint and I posted the PowerPoint on Moodle. Do you guys have any strong preference between a lecture capture, like we did with like a standard lecture capture with, and that's called TechSmith, by the way, as opposed to the recording in PowerPoint? There's pros and cons to each one, and what I'm worried about is that my audio is not quite as reliable when I'm using the PowerPoint recording for some reason. I haven't figured that out yet. So, but any strong preference? Are you guys able to handle PowerPoint files okay on your devices, or any clear? Gotcha. Yeah, it seems pretty essential for a recording like that. So I know it's sometimes nice to be able to break up the, with Camtasia, it's kind of a one-shot deal, right? In fact, I realize I'm still recording this right now, so I'm going to just hit pause on the recording. I'll take care of that in a little bit. Yeah, so if you get 15 minutes in and it's, kind of garbled up, it's easier when it's in a live group like this, or in a classroom especially. But if you're trying to create a good recording at home, it's nice to be able to go back and record just one slide, and you can't really do that with Camtasia. So I'm trying to use a little bit of a mixture, but it's good to know that both are doable, but yeah, maybe the audio is better in Camtasia. All right. Any other questions anybody has? All right. Well, chime in if you do. Otherwise, I think what I'll do is wrap it up here for today. But again, let me know if you guys have questions as you're studying, and I'll be accessible either via email or text. Okay, that's probably your best bet. And again, we can set up a virtual office hour like this as well. So that's something that we can do in the future. So let me know if that's needed. So
sounds good. Thank you.
You bet. All right. Thanks for connecting today, guys.
Thank you.
You bet. Have a good day. Talk to you later.
You too. Bye.